Good morning, everyone. If we could settle in, we'll get started with our keynote. My name is Kevin Brown. I'm from the University of North Carolina, and it is my absolute pleasure to introduce our keynote speaker. I think one of the great things about this organization and coming together like this is really the wonderful people that we get to meet and interact with, and I think that's why everybody is so excited to come to this meeting year after year. I've known Dr. Agrawal for about 10 years, and we've been collaborators over the last 5 years, and he's just really doing amazing work that is unlocking a lot of the mysteries of inner ear anatomy, and I would just like to introduce him and his talk, and can't wait to see what he's going to show us.
Thank you so much for the kind introduction, Kevin, and thank you to the ACIA committee for inviting me here to Washington. It's really a great honor to be able to speak to you all today. So just as disclosures, our lab has been funded through the Canadian Light Source, MITACS, NSERC, CHRP, and they're all Canadian funding granting agencies. All the IP I'll be showing you today is held by our university. We've tried to publish in open source journals, and we've given our data to international collaborators around the world. As disclosure, our lab has worked on some commercialization and patents, but none of that work will be as part of the presentation today. So I just want to thank everyone in my lab. It's been a 15-year journey, and I couldn't have done this without them. I want to thank our collaborators in Uppsala University, especially Dr. Rask Anderson. Without his amazing anatomic knowledge, we wouldn't have been able to unlock all the beauty within our synchrotron images. And last but not least, our collaborators at UNC, as Kevin already mentioned. I know a lot of you are here. You know, Kevin, Lisa, Meg, and the rest of the team. Without you, we really wouldn't have been able to translate this into patients. So the classic way we've been studying, cochlear anatomy our whole lives, our careers, has been through pathology. And you have beautiful contrast here. You can see all the nice structures. But the problem is that you have to decalcify the sections. You have to section them, stain them, mount them. Very expensive, labor-intensive, and you actually destroy the specimen in the process. For us, the most important thing was you really don't retain any of the three-dimensional anatomy. So you can try to reconstruct the slices, but there's a lot of artifacts when you do that. On the flip side, if you go to imaging, you preserve all the 3D spatial resolution. But as you can see here in a clinical CT scan, you really can't make much in the way of intracochlear anatomy. And even if we move to a 20-micron micro-CT, unless you put in contrast, you can make out the osseospiral lamina, but that's about it. So our goal was to try to meld the two techniques. Could we get 3D spatial resolution and have the amazing contrast that we see on histopathology? So we took all of our specimens to the synchrotron, which is located in Saskatchewan, Canada. And for people who don't know that, that's right in the middle of Canada. It gets brutally cold in the winter, and for some reason, we always get assigned winter shifts. Minus 40 degrees Celsius for people who work on the Celsius scale. Like I said, the only benefit is we don't have to worry about freezer space. We just store our human temporal bones outside, and they're just fine. So this is how the synchrotron works. So we have this big linear accelerator. We take electrons, we speed them up to the speed of light. It emits something called synchrotron light, which is a very high-powered radiation. Put it through a bunch of filters, enters this room with a stage, and hits a detector on the other side. And this is the actual room. It's about 30 feet long. Again, the beam comes in, hits the stage, and then goes to the other detector. So there's two problems. One, a 30-foot room, tiny temporal bone, getting all of that aligned, it's pretty difficult. And number two, you go to this facility, and there's no button which says scan temporal bone. So there's hundreds of parameters that you can set. So it actually took several years of work just to figure out how to set the parameters to even get any images. But once we did that, these are the set of projections we could get. Is that this is a temporal bone with an electrode inside. However, that's just kind of x-rays. So how do we get the contrast? So we used a concept known as phase contrast. So if we have monochromatic x-rays hitting a detector, we'd expect them to all hit at the same time. Now, if we stick a sample in the middle, two things happen. One, you get some absorption of the beams, which is like standard CT. But because of the refractive index of the sample, they actually hit the detector at different times. And so we can capture the timing difference as well. And if we move the detector further and further away, these timing differences get captured and accentuated. So if we combine the absorption with the timing, we get our phase contrast imaging. So what does it look like? So here's, again, a 625 micron helical CT. Again, looks like a blobby cochlea. You get the general shape. This is the exact same specimen with 20 micron micro CT, again, with no contrast. Looks much better. And then this is the image we get with Synchroton. And we can just see just the amazing resolution that's popped out. We can see the entire osseous spiral lamina, basilar membrane, Reisner's membrane, a lot of detail around the spiral ganglion and the medialis. But we didn't stop there, so this was our original detector, and we've moved to a higher resolution detector now. And again, if you compare the osseous spiral lamina between the two and the spiral ganglion, much more detail. And just a few months ago, we actually moved to a newer detector. So we had a new scintillator, we decreased our object to detector distance, we did a few corrections for beam decay, and putting all that together, this is now the type of image we can get. And we can actually start to see details within the organ of Corti, Reisner's membrane, stria vascularis. So we aren't quite at histology yet, but we're getting there. We're getting quite close while maintaining all the three-dimensional information. So we wanted to validate these results. So we did initial validation with Tina Stankovic when she was at Mass Eye and Ear. This is actually a virtual histology slide made from synchrotron images, and you can actually see the hair cell rows. We can track these hair cell rows here all the way up to the apex and track it all along the basilar membrane in 3D. We worked with our collaborators in Uppsala University comparing synchrotron against scanning electron microscopy, and again had very good correlation between the two. And perhaps most convincingly, we worked with Akira Ishiyama at UCLA, who had a patient who had a temporal bone who had passed away and donated their temporal bone to his lab. But before he destroyed it and sectioned it, he sent it to us. So we did a synchrotron scan, shipped it back to him, and then he sectioned it for histology. Because we had the same bone in two modalities, we could then merge them, and we can actually see the beautiful correlation of all the soft tissue versus synchrotron. But even though the bone was destroyed, we maintained a nice three-dimensional archive. So we could still go back and play with it. We could see all the fibrosis along the old cochleostomy, and we could even remove the bone and extract out the old electrode. So synchrotron has its advantages. So now we just wanted to start exploring. We're getting these cool images. Let's see what we can see. This is one of my favorite images. This is actually an incus. So that's the body of the incus, the long process of the incus, and this is actually the blood supply inside of the incus. So we can actually see how all the blood vessels flow within the tiny ossicle. And this is why we don't crimp our stapes too tight. You can see where the vascular flow kind of all conglomerates together. Just to orient you here, this is the incus, this is the stapes, and this is the incutostapedial joint. So you can imagine how small that is. At this point, we're seeing the entire joint capsule and even the soft tissue within the incutostapedial joint. This is a little bit disorienting, but now we're moving to the vestibular system. So this is the common crus. So this is where the superior and posterior canals merge. This is the endolymphatic duct exiting into the endolymphatic sac. This is an accessory duct. And we were even able to find this duct plexus that surrounds the endolymphatic duct all the way through. And Dr. Rask Anderson believes that this is involved in the pathophysiology of Meniere's disease. So now let's move to the cochlea, which is my favorite part of the inner ear. So here we can track the spiral ganglion all the way out to the apex. And what's interesting is spiral ganglion ends in this little terminal bulb, and that'll become important in just a minute. Here we actually track the vascular supply of the spiral ganglion. So here we have the cochleovestibular artery and the inferior cochlear vein, and we could see what a rich anastomotic network of vascular supply the spiral ganglion has around the medialis. Finally, we did some measurements of the spiral ganglion. So if we measure from the round window, it usually measures 650 to 690 degrees. But what's interesting is when we compare it across all our specimens, there actually is a lot of spiral ganglion variability. So individualization doesn't stop at the basilar membrane. Even if you're doing something perimedialar, it also needs to be individualized. Now we can take our spiral ganglion here in yellow, and we can add our basilar membrane in green. And we can see the relationship all the way up the cochlea. What's interesting down here is that the hook region, you can see the basilar membrane kind of gets further away and loops around the round window. So this is a very complex anatomy down here at the base. Because there's no metallic artifact in Synchroton, we can also put in implanted samples. And here we can clearly see each of the electrode contacts. We can see all the wires between them. What's really nice here is you can see the wire peters out to a single wire going out to the most apical electrode. What's also nice is you can see the relationship of the electrode to the basilar membrane and the fact that the basilar membrane hasn't been penetrated. So we can actually look at the amount of trauma or lack of trauma that different electrodes can have. Now, this image may not seem like much, but this was segmenting 30,000 images by hand over almost 2 years. So what we're looking at here is the spiral ganglion, the basilar membrane, and these are all the individual dendrites or peripheral axons connecting the two. So you can just imagine the amount of fine detail that went into extracting this. And if we put this together in the whole cochlea, this is the image that we get. So we can actually see the entire basilar membrane, spiral ganglion, and all of the connections. You can see they're radial along the mid portion of the cochlea, but as we come down to the base, you can see that they arc a little bit more basally. So if we tilt the view and look up at the apex, the opposite happens. These dendrites start to arc more apically towards the most apical part of the basilar membrane. One thing to point out here, and I mentioned that terminal bulb, if you look at this entire red and orange part of the basilar membrane, right, so we're looking at almost 3 to 4 octaves of low frequency hearing, it compresses onto this tiny little bit of the spiral ganglion in the center. So that little terminal bulb represents a lot of low frequency. So there's not a lot of spectral resolution if you're trying to stimulate the spiral ganglion alone. If we take all that information together across all of our specimens, we can then create these master maps. So we have the basilar membrane on top, spiral ganglion down low. Again, just to point out, if you take the orange, yellow, and red portions here, you can see they compress onto a very tiny part of the spiral ganglion. And we also have a little bit of compression occurring down at the base. So the question becomes, like, how do we start applying this? So the first thing we wanted to apply it to was cochlear pitch mapping. And I know we've already had some talks on this in this conference, so I won't go into too much detail, but cochlear pitch mapping essentially is the process of determining the tonotopic location of your postoperative electrodes. And as we all know, this depends on whether you have a big cochlea or a small cochlea, if you have a long electrode or a short electrode, and even where the electrode sits in any individual cochlea. So there's a lot of parameters that go into this. And why do we care about it? Well, with pitch place mismatch, there's been shown to be 1 to 2 octave differences when we look at single-sided deafness patients. In our bilateral patients, mismatch can cause less binaural sensitivity and sound localization. And Charles Lim has even shown that if you can reduce mismatch, you can also reduce pitch scaling errors, which has the potential to help with music perception. So how do we map the basilar membrane? Well, we can use something known as Greenwood's function, and I think a lot of groups have already talked about this. The only problem with Greenwood's function is that you have to know the total basilar membrane length in the formula. So if you don't know the total length of the basilar membrane, you can't really accurately map any of the frequencies. And now that's very hard to measure directly on a CT scan, so most people have tried to estimate it using something called an A value. So that's a measure from the round window through the medialis to the contralateral wall along the basal turn. And if you use this formula by Alexiadis, it should spit out a cochlear duct length of the basilar membrane. Sounds easy enough, sounds neat. But we found 2 things. One, there's a lot of inter and intra-observer variability in measuring this A value, especially finding this round window membrane, which is really hard to see. And second, the values just didn't add up when we tried to correlate them against our synchrotron. So we went through all this work. We thought we were really smart. We re-derived the equations. And after putting in all this work, it didn't help. So we made an improvement of 2 or 3%. So we just knew there's something wrong. Like, we just weren't getting really well-validated results. And I think this picture shows us why. So these 2 cochleae have the exact same A value of 8.7 millimeters. On the left, you have the big long apex. On the right, you have this tiny little apex. So the cochlear duct lengths vary from like almost 40 millimeters down to 33 millimeters. So even if you have the same A value, even if you have the exact same base, you can't predict what's happening up at the apex, right? So it doesn't matter how much work we put into these formulas, we were never really going to solve the problem. Now, other groups in Hanover have worked on more fancy equations that have been a bit more accurate, but again, until you know where that cochlea ends at the apex, there's still going to be inaccuracies. So Stakhovskaya took a different approach. She used histology at 45-degree increments, and just graphed the percentage length versus the angle of rotation across 7 or 8 samples. We thought this was kind of a nice, a nice method. The only problem is that one, she used 2D histology, so as you know, the basal membrane is a 3D structure, so she wasn't able to capture the hook region and other regions. And number two, if you reverse engineer the formula, she essentially assumes that every cochlea is about 1,000 degrees. So there's no individualization for a long cochlea or a short cochlea. So it was still kind of a one-size-fits-all answer. So we said, can we use our synchrotron data to derive a new formula that's actually individualized for patients? So we started with looking at the helicotrema, and this is an area at the very apex of the cochlea. And as you know, the basilar membrane doesn't go to the bony tip. It actually stops short of there. And this area is where the scala tympani and the scala vestibuli fluids meet, and they mix. So it's important for us to be able to correct for that, because we want to know the basilar membrane length, not just the bony tip length. So we did that. We got the mean length and the mean angle and created a correction. Then we started looking at the opposite end of the basilar membrane at the hook region. And you can see this area kind of loops around the round window and curves, so it's quite complex. And when you look at it across all of our samples, you can actually see that there's a fair bit of variability there. So we did some sophisticated modeling. We were able to represent this with a set of equations. And again, we came up with a correction for that part of the basilar membrane that we don't measure when we start at the middle of the round window. Finally, taking all of our synchrotron data, we were able to create these very high resolution graphs. So we have frequency on the y-axis here, angle on the x, and here's each of our individual samples. We have samples that end at about 860 degrees, and we also have some very long samples that go to almost 1100 degrees. So a nice size variation between the two. I'll also mention, it's not really a straight line. Do you see there's a bit of a curvature to it, like kind of a sinusoidal slide shape? So I'm not going to go through the derivation of our formula. We did publish this in IEEE, and it's an open access journal, so please feel free to download it, and it goes through all the derivation steps. But just to skip right to the very end, this is the formula that we get. It might look ugly, but it's actually pretty straightforward. Any frequency on the basilar membrane is a function of n, which is how big the cochlea is. That's the number of turns, so whether it's big or whether it's small. And the angle you're interested in. This ugly thing at the bottom was just that sinusoidal correction to correct for that slide shape. The nice thing about this formula is that it models the organ of Corti directly. You don't need any corrections for the helicotrema, the hook region, or even from the lateral wall to the organ of Corti length along the lateral wall. So it takes all of that into consideration. Now, just publishing a formula is not really enough, because you have to validate it. So we validated it against Stachowskaya. So what you're looking at here on the y-axis is the error in semitones. And you want to hug the 0 mark. So if you're along the 0, that means there's no error along all the degrees along the cochlea. Our individualized formula is in white. Stachowskaya's formula is in this kind of orangey yellow. And you can see that our function has less error. Now, if we do a leave one out analysis across all of our samples, this is what we get. And you can see pretty well in all cases, the individualized formula functions better. So we have reduced semitone error. So to kind of close off the arc, now that we have a formula, how do we apply this to patients? So we turn towards something called deep learning. And this is a form of artificial intelligence. So here you have a child learning how to differentiate an apple, an orange, or a pineapple just by looking at lots of different examples. And then we can actually train a computer to do the same thing, show it lots of different examples, and get it to learn how to differentiate. So what we did, put in a very large imaging database, and this is what we've collected over 15 years with synchrotron, micro-CT, cone beam CT, clinical CT, and we're talking about almost 20 terabytes of data. We've actually manually segmented all these slices. We have almost 1 million slices hand segmented with all the different structures. We put this into a computer to chew away at this for several months. And then this is what we get. So this is hand segmented. So this is a 300 micron cone beam CT, hand segmented by experts. Pretty nice shape, but you can see at the apex is not totally defined. But overall looks pretty good. If we put the same scan into our deep learning algorithm, so this is just one click, and within 2 minutes, it spits out this model. And you can see automatically it looks a lot better, right? The apex is cleaner. You can actually see where the stapes and the oval window will be. But just because it looks better doesn't mean it's accurate. right? So the computer could have just been making this up. Luckily, because these are temporal bones, we also have the gold standard micro-CT. And by looking at the micro-CT, this is actually the gold standard answer. And we can see that our prediction was very close to the real thing, and much better than the experts. So this is really good qualitative analysis, but we wanted to quantify it. So we did a quick validation study. We had 2 neuroradiologists and 2 neurotologists segment a bunch of different cochleae. And just to jump to the end, we have the DICE score on the y-axis, which is the amount of overlap. So the better this is, the more accurate you are. Here we have all the experts, and you can see it's not bad, about 88% accuracy in terms of overlap, but a fairly large variation. If we use a staple algorithm where we take all 4 of the expert segmentation, then merge them into one master segmentation, so it's almost like having 4 experts in a room and deciding to get the best one possible, the results got a bit better and maybe a little bit less variation. But compared against micro-CT, this was our deep learning. So we had statistically significantly better results, objectively, even based on DICE score, and much less variation. So it's one of the first times we have a computer that's beating the previous gold standard. So gold standard is always expert segmentation. That was the gold standard, and as a computer, you tried to match that. At this point, we're actually surpassing it. Just as a little bit of extra, the round window is also important for us, and that's often hard to see. But because we have the synchrotron scans, we could see it quite clearly, so we segmented them all out and also fed it into a deep learning network. And then it was able to successfully extract out the round window membranes on all of our samples. So now we get the cochlea and we get the round window. So what do we do with these segmentations? So we can do some geometric analysis, so we can automatically divide out the labyrinth from the cochlea and the different turns. We can find the basal turn plane. We can find the mid-medullary axis. What's really interesting is that the mid-medullary axis and the basal turn plane aren't perpendicular. The cochlea is kind of like the Leaning Tower of Pisa. The 3 stacks can be stacked one way or stacked the other way. So it's not just a straight up and down line. So calculating this is actually more difficult than it looks because you really need to make sure you're right through the 3 rings. We can take our cochlea and put it into kind of a standard orientation. But then we have to find the tip. And that can be tough because visually looking at it, you think the tip should be right around here. But how do we get a computer to do that? So we came up with a technique we call the tetherball technique. And so we take a little ball and we run it around in a bunch of little circles around the apex of the cochlea, creating a height profile. We can graph the heights, and we can see where this drop-off is. We can see where that drop-off is. I'll just skip it, but it would be where the apex would be of the cochlea. And then the computer can automatically take it and place the fiducial at your apex. So when we put this all together, we got the round window, we got the apex, and we can easily calculate the number of turns of your whole cochlea. We also created a final network that extracts the electrodes, so we can feed in a postoperative scan. It'll find all the electrodes for us, extract them in 3D, and then we can find all the angular length of each of the electrode contacts. Again, all with one click. So how do we put it together? Well, like we said, we found all the angular location of each of the electrodes. We found the angular length of the whole cochlea. We stick those 2 variables into our equation, and now we can tell you the frequency of each electrode for the specific patient, their size of cochlea, and where each electrode is sitting. So it individualizes the whole thing beginning to end. So just to finish off, the final question is you've done all this work, but does it actually work in patients? And this is where we really relied on our collaborators at UNC, and we really wouldn't have been able to get anywhere without them. These are very, very preliminary results. So these are patients who are just at initial activation. They're blinded to whether they have an individualized map versus the default, and the audiologists are blinded as well. And so we were nervous, so we just ran our first couple of patients through the trial, and this is what we got. So purple is an individualized formula, red is default, and they were performing better on words, phonemes, and vowels at initial activation. So we don't still have 1 month, 6 month data, so we don't know how this is going to pan out long term, and these are, again, coarse measures, but very exciting. So now I think we have a total of 12 patients. Subjectively, most of them prefer the individualized map just in terms of subjective sound quality. And we're now actually just completing ethics to start a randomized control trial between our 2 centers, where we're going to add longer-term follow-up and more advanced measures like music appreciation and localization. So in conclusion, new imaging technique, lots of nice resolution with it, new mapping function that I think reduces semitone error, and a kind of an exciting new deep learning algorithm that can automatically take out your cochleae, measure them, and pitch map them. And hopefully that'll form the basis of our new study. Thank you very much.
Thank you, Sumit. That was terrific. I think we have about 4 or 5 minutes for questions that we can take from the audience.
Hi.
David, how are you?
I'm all right. I don't think I need to specify, to preface this with, that's beautiful, this is wonderful work, I love it. You show these graphs comparing Stokowskaya versus your refined model. To my eye, with embarrassingly bad vision, it looks the big difference between those two is in the apex.
You're totally correct.
The rest of it is at least roughly the same.
Mm-hmm.
What I don't have a sense of, just I visually can't tell, if you assume that all commercial devices are inserted to 630 degrees or less, that's what a 31 is on average, how much difference is there practically for that range between the two estimates?
Yeah, that's an excellent question. So we've actually mapped the amount of mismatch per electrode
Right,
using an
that's what I'm
individualized versus the default. So, and I don't have those graphs with me, but we actually have mismatch as one of the axes. And so there's some patients who, especially in the UNC data, who have flex soft insertions with the default map who have very little mismatch. And the whole cochlea is matched quite well. So even if you individualize it, a couple of semitones here and there, it's really very much a fine tune. What we're finding is that when you have like a smaller electrode in a big cochlea or a really big electrode in a small cochlea where you really enhance that mismatch, that's where you see those two curves really diverge. And that's where the correction becomes the most important. So it may just be that if you have an average size cochlea, individualization may help somewhat, but if you have an abnormally large or small cochlea, this individualization will help you the most.
I'm sorry.
Yeah, go ahead.
So sorry, miscommunication. Are you comparing the mismatch between default and the optimized, or are you comparing, I'm asking about the mismatch between the Synchroton estimate and the Stokowskaya estimate.
So in our validation, we did it on Synchroton. So it wasn't on the default mapping, it was on the actual positioning. So using the Stokowskaya equation or our individualized equation on a Synchroton scan, what would it predict the frequencies to be at any given location? Right? And so we were looking at the theoretical optimal frequency, which we knew based on synchrotron and the dendritic measures. And then we applied our individualized equation to it, and we applied the Stokowskaya equation to it, and we were able to get an exact difference between the two profiles.
All right, okay.
So that's what we were showing. Yeah, exactly.
Great.
Thanks, David.
Thank you.
This is really wonderful work. I really enjoy watching. I've had a sneaking issue. I've been thinking about these issues about frequency mapping a lot, and it seems to me, maybe you can help answer this, that at some point we're making an assumption. We can do all the fancy analysis that we want, but you're still going back to relying on Greenwood, I believe, if I understand correctly, which is itself an assumption based on collected data in animals and humans, but sometimes cadavers, and there's no active mechanism, and there's all these assumptions that are being made at the root of it. And so no matter what we do to get the measurements as close as possible, is that always going to be a problem? And if so, what can we do about it?
Excellent question. You're right. And I wish I could give you something better than Greenwood's to go on. I don't have a better baseline theory as to how the basal membrane itself is mapped. All I can say is that the errors propagate one on top of another, and the errors become massive. So if you don't look at the hook region, if you don't look at the helicotrema, if you're just doing a lateral wall measurement and not measuring along the basal membrane, all of those are huge errors. So all of the estimates we've been doing till now, even if they're just based on Greenwood's, who knows how accurate Greenwood's is, they're not even accurately reflecting Greenwood's because we have so many other errors. So the goal of this was to really reduce errors at each of those steps. Reduce the manual measuring error, reduce the lateral wall to organ of Corti measure, reduce the helicotrema and hook region errors. And so we're just trying to get something that at least applies Greenwood accurately. Now, whether Greenwood is accurate or not, excellent question. And I'm open to trying to reinvent that portion as well. We actually have a lot more biophysical profiles and COMSOL models and things, we might be able to come up with something that's better. But our goal is at least everything downstream, we don't keep propagating that error and making it larger.
Thanks.
Yeah, welcome.
Well, thank you again, Sumit, for that amazing presentation, and we will conclude here. Thank you.
Great. Thank you very much.